Dear colleagues, today I present to you a case of omphalocele, which is a congenital anomaly characterized by the failure of closure and a defect of the anterior abdominal wall, resulting in the protrusion of one or more abdominal organs. These may include the intestinal loops, the liver, which protrude through a hernial opening usually located at the base of the umbilical cord, which is in fact involved and is typically found at the apex of the sac. This hernial sac, which serves as the container for these herniated organs, encloses them and is made up of peritoneum and amnion. The diagnosis can be made early, as soon as the first trimester after the 12th week of pregnancy, when the failure of the physiological herniation to resolve is assessed. This is due to the persistence of the abdominal organs, which remain herniated and are visible outside the fetal abdomen, contained within the hernial sac. The main differential diagnosis to consider is gastroschisis, which is also a defect of the anterior abdominal wall, resulting in herniation of organs, usually intestinal loops that are not covered by a hernial sac. Instead, they are free and floating within the amniotic fluid. The defect usually does not involve the umbilical cord. In fact, it is located more to the right of it, at the level of the anterior abdominal wall. This differential diagnosis is also fundamental from a prognostic point of view, since gastroschisis is usually not associated with chromosomal or genetic anomalies, unlike omphalocele, which can often be associated with this type of anomaly, as we will see later on. The issue of omphalocele can be related to various factors, among which in particular are its size and contents. In fact, it can be small, that is, less than 5 centimeters, and these usually contain mostly, or almost exclusively, intestinal loops. Or there are so-called giant omphalocele when they exceed 5 centimeters, so larger defects that can also contain part of the liver. Other factors can be the association with structural anomalies, in fact. 30 to 50% are associated with cardiac, renal, or possibly neural tube defects, such as cases of spina bifida or with syndromes. 10% are associated with Beckwith-Wiedemann syndrome, which is a disorder characterized by the association of omphalocele with macrosomia and hypertrophy of the fetal body, macroglossia, and visceromegaly. The association with aneuploidy can be another factor that may negatively affect the prognosis. In fact, we see that in 40 to 50% of cases, omphalocele is especially associated with trisomy 13 and 18. In cases of giant omphalocele, where the herniated mass is larger, and therefore, since it also contains part of the liver, it has been observed that the association with aneuploidy and chromosomal abnormalities is lower, only about 5 to 6%. In comparison, the association is much higher, reaching even 80 to 90%, in cases of smaller defects that contain mainly or exclusively intestinal loops. As for the association with structural anomalies, such as cardiac or extracardiac defects, the percentages are actually very similar, so the rates are quite comparable between the two types of defects, whether larger or smaller. Regarding the differential diagnosis, the main one to consider is definitely gastroschisis, whose characteristics we have already clarified earlier. Then there is also Cantrell's pentalogy, which is characterized by a defect not only of the abdominal wall, thus with an omphalocele, but also by a higher defect involving the thoracic wall, with cases of defects affecting the sternum, the diaphragm, and with ectopia cordis and cardiac involvement. Then there is also body stalk anomaly, which is instead characterized by a fetal abdomen with an omphalocele, a short umbilical cord, the body pressed against the wall of the gestational sac, or in any case, the placenta. And vertebral anomalies, with cases even of fetal scoliosis. And then there are cases of omphalocele associated with a lower abdominal defect, with cases of bladder extrophy, imperforate anus, and spinal anomalies. In the case of one examination, the patient came to our attention to undergo a first trimester screening with a neutral translucency scan. We can see the nasal bone. When evaluating the profile, we see the 3 ventronuchal spaces with an intracranial translucency within the normal range and a normal nuchal translucency of 1.8 millimeters. We also go on to assess the measurements, the crown rump length, which perfectly matches the gestational age, demonstrating that this is not a case of macrosomia and that we can rule out Beckwith-Wiedemann syndrome. The stomach is clearly visible, intra-abdominal, and the situs is normal. On the echocardiographic assessment of the 4 chambers, it is possible to see a small hyperechoic focus inside the left ventricle, very similar to a so-called golf ball seen in the 2nd trimester. On color Doppler evaluation, we see normal ventricular filling, though it is slightly reduced at the end of the left ventricle, which definitely warrants a thorough re-evaluation during the 2nd trimester scan at the 20th week. When sampling the valves, both the mitral and subsequently the tricuspid, they appear perfectly normal, without any signs of regurgitation, and are competent. Once again, we see the application of color Doppler. The trachea is also normal. Focusing now on the evaluation of the fetal abdomen, we see, as we have already observed previously, a stomach that appears intra-abdominal. However, the presence of these viscera herniated outside the abdominal cavity into the amniotic fluid, and the presence of this large hernial opening, which appears wide, indicate that this is not a small defect but rather a large one. Upon observation, even via transvaginal ultrasound, it is possible to visualize different levels of echogenicity, specifically the intestinal loops, which tend to appear more echogenic, and the contents within the fetal abdomen. We clearly see the stomach is still located intra-abdominally and is not herniated. However, we observe the presence of the umbilical cord, the defect at the base of the cord, and the cord inserted at the apex of a sac containing the herniated viscera. This echogenicity likely represents part of the liver herniated within the omphalocele defect. We observe the presence of the bladder, which is likewise located inside the lower abdominal region. So the bladder is not herniated outside, ruling out any potential cases of bladder exstrophy. And we can also identify a single umbilical artery. In the prenatal management of omphalocele, it is essential to perform serial ultrasound follow-ups, so an ultrasound is repeated every 4 weeks. This is done to assess fetal biometry and the increase in amniotic fluid, as well as to evaluate fetal anatomy, particularly in the later stages, during the developmental phase in the 3rd trimester, to check for the presence and association with anomalies such as cardiac or renal defects, which, as we know, are very common in cases of omphalocele. Usually, the defect, identified at 12 to 13 weeks, will then be reassessed after 2 to 3 weeks. And then again, at the time of the morphology scan, this is precisely to evaluate how the condition is evolving. In 90% of cases, it has been observed that small defects, which contain almost exclusively intestinal loops, tend to regress around the 20th week at the time of the morphology ultrasound. On the other hand, cases of hernia and larger omphaloceles, the so-called giant omphaloceles over 5 centimeters, which also contain part of the liver, do not undergo this type of regression. Instead, they usually require surgery at the time of birth. It is also important to always perform a fetal echocardiogram precisely because of the high risk of associations with cardiac anomalies in cases of omphalocele. It is also advisable to recommend genetic counseling to assess the possibility of an invasive prenatal diagnosis with the acquisition of the fetal karyotype. Thank you for your attention.